So, welcome to Pharm, right? Everyone's here for the right class. Should be 30 of you in total, I believe. I counted 30, so that's good. Starting off, I'm Dr. Wood. I'm a pharmacist by trade. I'm a clinical toxicologist by further training. Does anyone know what that means when I say clinical toxicologist? So if you like overdose on something, or if you get bit by a snake or a spider, any kind of creepy crawly, you call the poison centers. I'm one of the people that works there, right? And when you think of pharmacists, like, what do you normally think about? Like, what comes to your mind? Walgreens, CVS, Publix, yeah, totally. And a lot of pharmacists do work in the retail setting. That was not for me. I'll tell you a funny story later on about my second day working at retail and why I don't work at retail anymore. Suffice to say, a knife was involved, but I work mainly in the hospital, and so my primary background is in pediatrics, it's in emergency medicine, it's in toxicology. I still work 1 day a week over at Nemours Children's Hospital, and so that provides me with a lot of good clinical experience to bring back to you guys. I can tell you about something cool I saw on Monday here on Friday, right? So again, that's my background in terms of what I do clinically, what I do full time. I usually teach over at Nova Southeastern, so I'm sure anyone have friends over there. Anybody's in their class? Yeah, so again, I love all my PA students exactly the same, and you're getting almost an identical curriculum, right? The hours may change a little bit, but don't feel like, do you like us better or them better? Like, it doesn't really matter. Everyone gets basically the same farm curriculum, which is good because that means that we are all producing the same kind of quality PAs. So, anywho, what have you heard about the class prior to coming to today? Anything challenging? It's a good word. It's a very puts a positive spin on it. Any other words that maybe not quite as positive you've heard? Interesting. Oh, well, thank you. That's very nice. I had to pay them liberally to make that happen, but fortunately, yeah. So anyway, yeah, this class is tough. This class in particular is not going to be quite so bad because this is like the introduction, right? This is basically the building blocks of getting into Pharm 1 and 2. That's where the training wheels really come off and we really hit the ground running, so to speak, right? To mix my metaphors a little bit. And so you'll find this class probably you'd be like, oh, this doesn't seem so bad. What are they talking about? In Pharm 1, that's where it's really going to really kind of get a little bit tougher. So not to scare you, but just be kind of cognizant of be like, okay, well, this is a little bit different of a course than what you're going to see next semester. This is how the grades are going to be divvied up. So you're going to have 4 homework assignments. Each of those will be worth about 5%. The last one's actually going to be like a prescription writing assignment, and that'll be indicative of the rest of the homework assignments for Pharm 1 and 2. That way you actually get like good experience writing in hospital orders, outpatient orders, etc. There'll be 2 shorter written exams that will be done. Again, they're going to be maybe like 25 questions or so, probably half what you would normally do. It's really trying to get you up to speed for the final exam. That's going to be cumulative, so it'll cover the entire topic here, the whole class here, and that's going to be worth 27%. So that'll be like during your finals week. There's also a professionalism grade. Please don't disappoint me by being the first people to not get the full 3% on that. So, guys, keep it professional, people. All right. Any questions about that? It's pretty straightforward. There's a lot of grades involved here, so even if you do bad on one thing, like don't worry too much. Like there's other ways to bring it up, so just be aware of that. Okay, not like extra credit stuff, but you have other assignments that can kind of help yourself out a little bit. Again, so just a couple tips that I will mention in terms of my class and how to do well in it. One, are you guys competitive at all with each other? Don't be, right? Because again, you're in your terminal degree. There's really no competition left here. So really utilize each other as a resource, I would recommend. There's going to be some people who take my class and they find that they have no troubles with it whatsoever. They read it one time, they're like, I'm good to go, right? If you're struggling, those are probably not the best people to talk to because you'll be like, well, what's your secret for success? And they say, I just read it and I know it. Like that's not so useful. But you will have some people who really have to like come up with good memory aids. They'll have good study guides. They'll have good tips to try to remember the stuff a little bit better. Those are the people you want to talk to, right? If you're having a hard time, again, collaborate with them. Try to figure out like what their strengths are, what your weaknesses are, and try to meet those up together to see how you can try to succeed here. Okay. Other things to mention: make sure you get plenty of sleep, please. I can't tell you how many students I've had who have been like, I'm struggling, I don't know what to do. And I say, well, how much sleep did you get the night before the exam? And they say, well, my roommate had to bang down the door at 20 minutes till the exam because I had overslept because I went to bed at 4:30 in the morning. I was like, well, maybe you should get a little more sleep and that would do better. And sure enough, like 2 weeks later, they came back and said, oh my gosh, that was the best tip I'd ever gotten. It's kind of common sense, but when you're in the throes of PA school, it's very, very tough. And it's very easy to say like, well, I could get that 2 hours of sleep or I could get 2 more hours of studying. But if you're so tired that that 2 hours is basically you don't remember any of it, then that's not very useful. You're better off getting that sleep there, right? So again, kind of hedge your bets a little bit in terms of your body actually functioning as opposed to, you got it? Cool. Fantastic. Thank you for sending that out. Anyway, so that would be one thing I would mention there as well. Other things to do as far as resources go, utilize me. Please utilize me earlier rather than later. If you don't understand something, I'm more than happy to talk to you via email. We can do Skype. We can do in person after class. Whatever you want to do, we can set that up. That's no problem. The one thing I don't really appreciate is when you wait till after you fail an exam or something and come up and be like, oh, I didn't know what I did wrong. And I was like, well, why didn't you come beforehand? We could have talked about it and figured it out, right? Those are the things I'd prefer to see, is try to come early, ask questions often. That's going to be useful. One other thing, and again, I should probably send you this link too, but there's going to be something called the sticky board. You probably won't need it for this class here, but you'll see a link to it when you actually get access to the class, hopefully on Monday. You can post little sticky notes on here during class, and this will be stuff that I will answer as we go along, so like at the breaks and at the end of class. So if you have a question and you're a little too shy to ask it in the middle of class, just go ahead and put a sticky note up there, and that way you can ask it and we'll talk about it. It's anonymous, so I don't have to see who it is or anything like that. And I do encourage you to ask questions during class. If I say something, you're just like, what the heck is he talking about? Or you don't have any context or something, like, let me know. We can talk about it, right? I'm very happy to digress off into weird territories and then just read off the slides, right? Anything else? Oh, say for instance, Dr. Levine is saying something, or Dr. Murray is saying something, and I say something that's contradictory to that, that's okay, right? Is medicine black and white? You will find, if you haven't found out yet, that no, it is not, right? It'd be nice if it was, but it is unfortunately not. And as students, you really want to have things in black and white, yes or no type of answers. That's not always the case. So again, the tactful way to handle that sort of situation where you have kind of competing ideas from different professors is just go talk to them. Just be like, well, hey, how come you said this, but this other person said that? Oftentimes it's a matter of perspective, right? So I'm coming from the pharmacist perspective that is different than, say, the physician or the PA perspective. And by melding those together, you get a better picture in general of medicine, how it actually works out there in the real world. So again, don't just be like, well, so-and-so said this, and so you're wrong. Like, not super tactful. You're not going to get a whole lot of leeway with that, right? So always be curious instead of judgmental when you're asking your questions, and I think you'll get a lot more, a lot more utility out of that. Anyway, so any questions so far? Just kind of, yes, ma'am.
Just kind of side note for the July 4th, we have class on Wednesday that week.
Yes, yeah. So that is the one day that I think the schedule is going to be a little off, and so when you get, when you see the syllabus, you look at the schedule here. Again, don't worry about the year. I was just not very attentive to the actual year that we're in. We are in 2019, as it turns out. But you'll see here that the only day that's not a Friday is that July 4th week. Hopefully you guys don't mind not being here on the Friday. You'd rather be. Dr. Murray thought you'd prefer not to be here on that Friday, so I said, okay, I guess I'll have a break this one time. But Christmas Day, you're going to be right here, right? We're talking for. I'm just kidding. No. Yeah, so again, that's the only day. Please be here on Wednesday. I'll put an announcement out beforehand, just to make sure everyone knows where to be, okay? All right, anything else before we get started to the actual topic at hand? Again, you'll have a homework assignment. Everyone will be assigned a drug, so go through that Excel sheet. You'll see what drug you're assigned to. I apologize if it's something you're not all that too interested in. Most of the time, you don't even know what it is, so you can at least look it up and find out. And then there'll be some questions to answer about it. I will recommend, you guys know how to get to UpToDate? Okay, so get to UpToDate through the library website, and from there, UpToDate is linked to a database called LexiComp. That is what I mainly use as my drug reference du jour, so to speak. They're owned by the same company, so you can get to the monographs from there. Again, you can Google things, you can find the information elsewhere, but just be aware that it may not be as quite a reputable source as something like LexiComp. So, and that link will be there when you get access to the site as well. So again, I apologize for the mix-up. I had no idea. Anyway, so let's get started with. Oops, I don't want to open that up. Yes, sir. You can list a source. I'm not too worried about the formatting. I'm not going to get too big into that. However, I do have turned on those. So again, I would recommend not copying and pasting stuff. If it comes up like blaringly red, And I look at it, I'm like, well, obviously you just copy and paste this from our website. That's not really going to be too great. I might turn that back to you to redo. So you can write it in your own words. Again, the idea here is you're not going to be a little pharmacist yet, but I want you to at least start to think critically about, okay, when it says mechanism of action, what does that mean? Like, how do you actually convert that into something I can express? One of the big things you'll find I'm trying to teach you as we go along is that patient education is 9/10 of what your job should be in terms of making sure the patient understands what they need to do in order to be a good advocate for their own health. And so if you can't explain things to them in a way that they understand, then you're not really doing yourself any favors, right? So you can say, well, you have hypertension because your renin-angiotensin system is overloaded, and this is why I'm giving you an ACE inhibitor. That's going to go over the heads of a lot of people. I probably went over some of your heads already, right? The point is you're going to get to that knowledge, right? And you're going to be able to bring it down to their level and be able to explain things in a good way. And so that's what these assignments are trying to help out with, is to try to, you look at the information, which may seem kind of foreign, and try to convert that into something that's a little bit more usable, okay? So you'll get the idea for it once you actually see the assignment and work through it. It'll be due next week before class. So.
Are you saying, is that the drug assignments are doing the same drug the whole semester?
Yeah, you'll do the same drug for all 3 assignments, yeah. So, and then the last one will be a prescription assignment, so everyone will have the same thing they're working with there.
Gotcha.
Okay. Any other questions before we get started? I guess as far as like medical background, so who has previous medical experience? Most everyone, right? Because you had to get into PA school with some experience. So who are my like MAs? Any scribes? Okay, a couple scribes. Any respiratory therapists? No. Any paramedics or EMTs? Okay, got a few there. Any pharmacists by any chance? Any pharmacists by any chance? I've had one pharmacist who was going back to be a PA at one time. She was very good at taking all my tests, as it turns out. Any physicians? Got one? Okay. Any nurses? No, very good. All right. So, yeah. So again, and I really appreciate if you've had a previous experience with something, and you're like, oh yeah, like when I saw it, and it was like this. It may be a little bit different than how I explain it. Bring that up. I like to compare and contrast different experiences, and again, that gives us a better full perspective on kind of what medicine is when you actually get out there to practice it. So, without further ado, getting into the class itself. Again, this is just the introductory course to Pharm. You're going to find that, and again, if you can't hear me in the back, let me know, and I'll try to speak up. Sometimes a helicopter likes to go off and probably have to like stop for a few minutes there. Sometimes I like to think that the helicopter just hangs out there and they just kind of hover just to interrupt my lectures, but anywho, so this is the basis for Pharm 1 and 2. If you don't have a good understanding of the concepts here, you're going to struggle, right? Because again, you need to know how to talk in terms of, the vocabulary, the lingo, all those sorts of things, in order to get into talking about bugs and drugs and talking about antihypertensives and all these different things here. Again, you have 14 hours of instruction, so we'll have 7 class periods here, 4 homework assignments, and those 3 tests. The last one is the cumulative 50-question typical sort of test that should be pretty representative of what you'll see kind of going forward in Pharm 1 and 2. And you need 75% or greater on the test to pass. I would recommend you all will, I suspect all of you will do just fine on that, so no worries. Anyway, getting into some definitions. So when you're actually getting into talking about medications here, so we're talking about the drug names. There's 2 primary names you're going to run into, right? So there's trade names and generic names. Anyone know the difference between the 2? Or could you explain it? Nothing at all. Again, feel free, even if you're wrong, like we'll talk about it, right? So again, don't feel embarrassed if you want to say something, like just blurt it out. Like I have no problem with that. So trade names are typically going to be what the company sort of brands the drug with, right? So when you hear something like ibuprofen, that's going to be the generic name. That is the chemical moiety you're dealing with, right? When you say Motrin or you say Advil, that is the trade name, right? I will tell you for all of my exams, I will put the generic and the trade name. Again, that is to get you exposure to seeing these things. I will tell you on the pants, though, they will only have the generics. So when you're studying this stuff and you're learning it, I would recommend at least knowing the generics. Knowing the brands is good too, because again, when your patients are talking to you, they're going to say, oh yeah, I took Advil. And you need to be able to equate that back. Okay, I know that's ibuprofen. Okay, so it's an important distinction to make there. Anyway, now getting into the actual pharmacotherapeutic classification, very frequently this is based off of the mechanism of action of the drug and how it actually works within the body. So as an example here, ibuprofen, you probably heard the term NSAID before, right? That stands for non-steroidal anti-inflammatory drug. So based off of that, what do you think the drug does? Reduces inflammation, right? Is it a steroid? No, because it's non-steroidal. Perfect, right? So I know a lot about that drug already. I know it's not a steroid, and we'll talk a lot about steroids and some of the pros and cons of those. But it's a non-steroidal drug, and I know it's an anti-inflammatory. Boom, I know a lot about that drug already. further getting into the actual mechanism of action, we'll talk about this. This works as a cyclooxygenase inhibitor, right? When we get into talking about inflammation, we'll talk about the COX enzymes and how they mediate inflammation, how they mediate things like fever and pain and all of that. And we'll talk about how that enzyme works here. This is an inhibitor, right? In some cases, you're going to find drugs are going to be enhancing things, and sometimes we're going to be blocking things, as the case may be. And so we'll kind of look into that in each case there. But again, you want to be able to equate, okay, this drug, ibuprofen, I know it's an NSAID. What do NSAIDs do? NSAIDs block the activities of cyclooxygenase. And then from there, you're going to know exactly what it does from there, right? Okay, well, I know cyclooxygenase produces prostaglandins. I know that's what causes inflammation. You also know a lot about side effects as well when we get into it, okay? So don't worry if you're getting overwhelmed right now. It's okay. We're going to get into those details when we actually cover the drug specifically. I just want to give you an idea of sort of the thought process you're going to have by the time you get out of here, okay? Anyway, and as an indication, you can see we can use it for specific uses, right? Some of these are going to be FDA-approved uses where the company submitted and they say, hey, we want to use this drug as an antihypertensive. And they'll say, okay, well, where's your studies to prove that? They'll supply that and they'll say, okay, boom, you have an indication. Now, does that mean you can only use the drugs for those indications? No, this is what we call off-label use, right? There's a lot of drugs that get used for other purposes than just what it's been indicated for by the FDA, okay, the Food and Drug Administration. So as an example here, the indications for ibuprofen would be it's an anti-inflammatory, which you knew that based off of the actual categorization of the drug. It's a analgesic, which means what? Pain reliever, good. And it's an antipyretic, which means what? Reduces fever, perfect, right? So you already know the indications for ibuprofen. Well, we could also use it for other things, right? I can actually use ibuprofen. There's an IV form that you can actually use to close a patent ductus arteriosus for neonates. Now, is that an approved indication? Not for this specific variety, but again, that's another thing that may be considered off-label that you're using it for, right? So anyways, there's things to keep in mind. So getting into the definition of pharmacology itself, again, this is looking at the interaction between the drugs entering the body, the interactions between drugs potentially, and then you'll find that it gets broken down into two kind of big umbrella categories. And so this is going to be the pharmacodynamics and the pharmacokinetics. We want to take a stab at what the difference is between the two. A really handy way to remember this is that pharmacodynamics is what the drug does to the body. So if I give you ibuprofen and your fever comes down, that is the pharmacodynamics of the drug, right? If I talk about how the liver metabolizes ibuprofen and how your body interacts with the drug, what the body does to the drug, that's called the pharmacokinetics, okay? You're going to see that gets into how the drug gets absorbed, how it gets distributed amongst the body, how it gets metabolized, and then eventually how it gets out of the body, right? So again, there's no drug that you're just going to give a one-time dose and be like, all right, we're done. Don't have to ever do that again, right? Because it's going to leave the body eventually. So you're going to find that we have to talk about those sorts of things in terms of the kinetics to see, well, how do I dose this? Do I dose it one time a day, twice a day? All those sorts of things. So again, when you're looking at the pharmacodynamics, we're talking about the mechanism of action of the drug. We're talking about the relationship between things like concentration and the effects you're going to see there. And remember, this all goes along a spectrum, right? So for instance, I can give you ibuprofen and sure, get your fever down. But if I were to say keep giving you increasing doses, do you think I would keep seeing your temperature go down lower and lower and lower and lower? No, right? But what I would see is I start to see toxicity start to develop. Maybe I start to see GI toxicity start to happen there, right? Maybe you get a peptic ulcer. Doesn't give you too big of a dose for too long a period of time. Toxicity and the clinical efficacy of the drug are all along the same spectrum there, and that's why it's really important to look at things like dosing and how we're going to be achieving those concentrations in order to get the desired effects while trying to minimize the toxic effects. Now, is there any drug that I can give that is completely devoid of adverse effects? No, right? So again, we know that that's an inherent risk of giving a medication, and so it's important to be knowledgeable about what those could be and how to mitigate those if possible for your patients there, right? There are certain chemotherapeutic drugs which I know if I give it to a patient, it's going to eventually cause a cardiomyopathy, and they're going to get a heart failure from that, right? But they're also going to die of the cancer if I don't give them that drug. So it's important to try to make sure we're maximizing the efficacy versus the toxicity that we're going to be dealing with. And that's all part of the dynamics here. So as an example, let's look, and again, I always use ethanol as an example. Now, I'm sure all of you are fine, upstanding individuals, have had no exposure to ethanol whatsoever in your life, right? Okay, but you can at least imagine someone who might have had some exposure to ethanol, possibly. Look at the different dose effects that you can see with alcohol and its effects on people, right? So again, alcohol is a drug just like anything else, even though it's not managed by the FDA. But low dose, what happens with alcohol? We get that loss of inhibition. You're feeling pretty good. Maybe I'll go talk to that girl over at the bar, right? A social lubricant sort of effect there. That's a low dose sort of effect there. Okay, it's maybe 1 or 2 drinks in. Let's say I get a few more drinks in. What happens then? Well, then I start to have slurring of the speech. I start getting coordinated. I try to go walk over to that girl, and I'm ataxic, so I end up stumbling and falling and cracking my head on the pool table, right? That's a medium dose sort of thing you might see. Even higher doses than that, that's where you start to see loss of consciousness. This is where you can see respiratory depressions, where people can die potentially, right? And so again, it all has to do with the dose that you're administering and what sort of effects you're expecting to see there, right? It's all the same mechanism of action. Ethanol is doing the same thing at every step along the way. It's just a matter of how high a concentration it is and how big of an effect you're expecting to see, okay? So again, it gives you an idea of what the drug itself is doing to the body. Now, kinetics, as I mentioned, is what the body is doing to the drug. So we're talking about how drugs get into the system. And again, what are some different ways drugs can get into the body? Oral is a very common one. What else? IV, probably the second most common one. IM, sub-Q, rectally. I mean, there's lots of different ways we can do it, right? All of that goes into the absorption of the drug, right? So we'll talk about those sorts of things. We'll talk about the concentration of the drug over time. We'll talk about things like half-life and how long drugs stick around in the body. But again, all this goes back into how the body is handling that drug. Because again, the body sees it as foreign. It sees it as a poison. It wants to get rid of it in general. And so this is how the kinetics are going to be described here, right? How a drug gets absorbed, distributed, metabolized, or broken down, and then eventually eliminated, right? Okay, so again, looking at ethanol again as our example here for our pharmacokinetic differences, imagine, and I imagine all of you would be an alcohol-naive sort of patient there, right? You don't have a lot of exposure to it all the time. You may metabolize or break down ethanol, say at a rate of 20 milligrams per deciliter per hour. Anyone know what the legally drunk limit is? It's 80 milligrams per deciliter. If you're at 0.08, right? You ever blow higher than that, like on a sobriety test, like you get sent to jail, right? So again, if I had a level of 0.08 or if I had a level of 80 milligrams per deciliter, it would take me roughly 4 hours to get rid of all that alcohol, okay? That's if I had little to no exposure to alcohol, on a routine basis. How about chronic drinkers, though? You'll find that chronic drinkers, they have differences that occur. Their liver adapts to having the ethanol around all the time. You may find that they can metabolize that 3 to 4 times higher than what a alcohol-naive sort of patient would, right? That's a pharmacokinetic change that occurs that we know about that happens in people who are chronically exposed to alcohol. Now, you're going to run into people who are chronically exposed to alcohol in the real world? 100%, right? It's a very commonly abused medication out there, even if you don't consider it a medication, but it's a commonly abused substance, and so you're going to find that they will have different kinetic profiles than someone who is alcohol-naive. Anyway, and again, that has to do with the liver increasing the numbers of enzymes available to break it down. Lots of other factors that go into that. But again, this is what the body is doing to the drug itself. Okay. And again, you can kind of break down the two categories here into the kinetics being once the dose is administered, how it gets absorbed, how it gets to the actual site of action, wherever it happens to be, whether it's the heart, whether it's the brain, wherever it happens to be. And then once you're actually there at the tissue, that's where the pharmacodynamics really kick in. Okay. And again, this is where you find the efficacy. This is where you find the toxicity. In the meantime, some of that drug is going to get distributed to some of the other tissues here. You're going to find it's going to get excreted or metabolized, and so we'll get into all the details there. Now, are you going to know every single metabolic pathway for every single drug you're ever going to deal with? No, even I don't know that, right? I look a lot of stuff up if I need to, but you're going to know the important ones. You're going to know the common interactions you're going to run into that may have some clinical import on your patients. So we'll get into those details there where it's appropriate. But again, this is generally what your body's doing with the medication at any given time. Okay, pharmacogenomics. If you had to guess, what do you think that is? How do your genes affect how your body handles drugs, right? Some people may be more sensitive to a medication because their genetics predispose them to being more sensitive to it, right? Some people may be fast metabolizers. They may be slow metabolizers. A lot of it goes back to what is your genetics, okay? Now, again, this is a hot area of research in pharmacology. You'll find that we're still looking at a lot of these things. But in some cases, we know that there are certain enzyme changes that occur based on genetics. So we can look this stuff up beforehand. We test a patient and say, hey, you have this enzyme. I don't want to give you this drug at all. Or I can adjust the dose of the drug to make sure it's going to be efficacious for you, not toxic. So again, that's pharmacogenomics. And again, if you ever hear me talk about that, it's specifically what it is. Again, as time goes on, as those tests become cheaper and easier to run, you'll find that there'll be more dosing recommendations based off of those patterns there. A lot of them are too expensive to run on a routine basis, and so we just don't do it. But if you see a patient and you say, man, they're really sensitive to that drug, how come they got that side effect? I wouldn't have expected them to. A lot of it has to do with their genetic predisposition. So anyway, getting into it, drug, medication, different names for the same thing essentially. You kind of think about drugs and receptors in terms of a lock and key, right, in terms of actually having its effect within the body. So a drug, we're going to consider any substance that brings about some change in biologic function. If it lowers your blood pressure, if it's going to increase your heart rate, if it's going to slow down the neurons in the brain to stop a seizure, like those are all the physiologic actions. Those are being caused by our individual drugs, okay? The receptor very important. These are the targets for the drugs where they're actually going to be interacting with it, right? So you're going to find that we have different types of receptors. We'll have a whole section on that later on that talks about where you find them and where they how they act. But again, this is what the drug's going to interact with. Let me find some drugs will activate those receptors to get some sort of effect. Sometimes you're going to find that the drugs are going to block those receptors and prevent them from doing something. Okay, and so you can find that enzymes, transporters, DNA can be a target for medications, right? All these different things are going to be potential targets. Really, almost anything can be a receptor, so to speak. Okay. And again, we're going to talk about their function in terms of upregulation, downregulation, how that's going to affect how a person responds to a drug. And again, we're going to get all into those details later on. Just know that the receptors are the targets for the drugs where they're actually having their mechanism. And again, you can kind of see here in general how the whole process is going to be. When I apply a medication to a patient, they're going to find that there's going to be an equilibrium that is established between the drug coming into contact with the receptor and actually causing this binding to occur. Now, when a drug binds to the receptor, you think it's there permanently? Generally, no, right? Again, it's going to be an equilibrium. It'll bind, it'll have its effect, and then pop back off. In general, some bind very tightly. Some do form a permanent bond. It just depends on the situation. But in general, they'll pop back off, and you're going to find that if I were to increase the concentration of the drug, you're going to increase the concentration, the number of receptors getting hit. If I lower that dose of the drug, lower the concentration, fewer receptors are getting hit there, right? And so again, that goes back to talking about how what type of effects we're going to see based on the concentration of the drugs. I have a whole section on that later on. So a ligand is just going to be a generic term. You've probably heard it before in either like a bio class or a biochem or something like that. Basically, it's just any kind of molecule that binds to a receptor. It's a little bit more of a broad category. It can include a lot of endogenous ligands or things that we're producing ourselves. So as an example, you can think about insulin as being a medication that we can give a patient who has diabetes, but also a ligand that we produce ourselves that interacts with insulin receptors to cause, what does insulin do? It drops your blood sugar, right? Because it helps your body, your cells to absorb that blood sugar to use it for energy, right? Turn over into ATP, and now we got energy to move around, do whatever we want to do, right? So anyway, again, we're going to find that a lot of the medications we're dealing with are going to interact with these ligands, right? They may try to enhance their effects, they may try to inhibit their effects. It all depends on the disease state we're dealing with, the medications we're dealing with, etc. So as an example, neurotransmitters are a popular one, right? So you guys are familiar with depression. What are a class of drugs we use for depression? SSRIs. Anyone know what that stands for? Selective serotonin reuptake inhibitor, right? The category already tells you exactly how that drug works. It blocks the reuptake of serotonin. That's a neurotransmitter that's very important in the process of treating depression, anxiety, etc., right? So that's one example. Hormones, I mentioned insulin already, cortisol. Again, you're going to find that your cortisol levels are going to be really upregulated for most of the next 27 months or so. Medications fall in this category, messenger molecules, all these different things all fall into this category of a ligand. Anything that interacts with the receptor is considered a ligand. Now, it's a hormone. Basically, it's some kind of messenger molecule that your body's going to be producing in order to interact and cause some downstream physiologic effect somewhere else. So as an example, if I were to release insulin coming from the pancreas, and then it goes and interacts with my skeletal muscle to cause uptake of glucose, right? That's a hormone in that case there. Cortisol causing your blood pressure to rise and your gastric ulcers to start to develop because you're stressed out about your pharm exam, right? Those are all hormones. They're basically messenger molecules. You'll find, again, popular targets for our drugs to interact with, either enhancing the effects of, replacing, or inhibiting, as the case may be, right? And again, xenobiotic is just another kind of generic term. Really any chemical compound that's foreign to a living organism, right? So for instance, I can give exogenous insulin to a patient. That really wouldn't be considered a xenobiotic. But if I give a drug that stimulates insulin secretion, that would be a xenobiotic. It's a foreign molecule that your body does not produce on its own. Now, this is stuff I love, of toxins, toxicants, basically anything, or actually can, when you consider, like, can something be poisonous or not? Can water be poisonous? 100%, right? Because I don't know if anyone's, maybe you've aged out of it, some of you. Anyone remember the Nintendo Wii when it first came out? There was a contest. It was really hard to get a hold of one. There's a contest called Hold Your Wii for a Wii. It was a radio contest, and they basically had to drink a ton of water and see how long you can hold your urine for. And whoever held it the longest, they got a Nintendo Wii. What happened was, all that water, guess what it does? It dilutes out a lot of your stuff in your blood, namely sodium. The patient became very hyponatremic, developed seizures, and died. Whoops, right? Water can be poisonous, right? Oxygen can be poisonous. Anything can be poisonous. It all depends on what? the dose, right? How much I'm actually giving to a patient there, right? Some things are poisonous, and no matter what the concentration, like lead has no role in the human body, should never be exposed to it if possible. But other things can be very therapeutic at certain doses, very toxic in other doses. Okay, and again, toxicology is just that study of those toxins, how it's going to interact with the body, how we treat it, how we manage it, if there's any antidotes, things like that. Keep in mind, it's kind of just a bit of semantics here. If you ever hear toxin, that is usually something that is of biologic origin. So when you think about things like snake venom, thinking like botulinum toxin. Now again, which one of those is a medicinal product? Botulinum toxin, right? So if you ever give it to your patients as Botox, if you go and work in derm, that is considered a toxin, right? It's actually one of the most potent toxins in the entire world. You can kill a lot of people with it. So again, it's good that we're injecting it into our faces for beauty purposes. But listen, I don't want those crow's feet and then those 11s, or I just learned about the 11s recently. But anyway, very important to know, like, how do we use this appropriately? There's a case where somebody was using Botox that was not diluted appropriately. They got way too much. The patient got paralyzed, diaphragmatic paralysis, and died of respiratory failure, right? You got to be careful with this stuff in terms of how we're managing it, right? And again, toxicant would just be anything of non-biologic origin. So again, lead, pharmaceuticals, anything like that is considered toxicant. I'll probably use the terms interchangeably, though, not really a big deal. Anyway, so getting into when you're actually talking about drugs interacting with the receptors itself, or really any ligand interacting with the receptor, we have what we call an agonist. An agonist is going to be anything that activates that receptor to cause a positive effect. Now, when I say positive, I don't mean like good effect. I just mean a positive, meaning it increases the activity there. So, for instance, if I were to give you exogenous insulin, I give you a sub-Q shot of insulin, that's going to agonize those insulin receptors, and it's going to cause blood sugar to go into the cells, right? Now, again, it can be a good thing if your blood sugar is, say, 300, but if your blood sugar is already 100 and it gets down to 40, that's a bad thing, right? So, again, not necessarily to be a good effect, but it's a positive effect. It's causing that thing to work more so. Okay. Again, it can be directly, indirectly. Don't get too hung up on that. But as another example, everyone familiar with the drug albuterol used for asthma attacks, right? That is a beta-2 agonist. We have beta-2 receptors lining the lungs that we give that, and it will cause smooth muscle relaxation, right? It will cause those bronchioles to open up. Patient can breathe a little easier, can oxygenate a little bit better, right? That's an agonist on the beta-2 receptors, okay? Insulin is another example, as I just mentioned there, okay? Now, when you're talking about how these drugs are interacting with these receptors in terms of agonists, you're going to find that we have a couple different topics we'll talk about here. So affinity is how tightly a drug binds to the receptor. You can have things that have low affinity, which doesn't really bind that tight, or you can have things with really high affinity that bind very, very tightly. There are some clinical cases where that actually becomes really important. So as an example, I talk a lot about opioids, because again, we're in the middle of an opioid epidemic. It's something you're going to be dealing with day in and day out when you get out there, most likely. We have certain drugs. So anyone ever heard of the drug Suboxone? It's used for opioid addiction to try to wean people off of it. If a little kid gets into that, it can be very difficult to treat because that drug binds so tightly to that receptor that it can be hard to get the antidote to kick it back off, right? So again, you can have high and low affinity drugs. That also goes into the potency of a drug. When I say potency, anyone know what that means? Kind of the strength of the drug. How much do I need in order to get an effect, okay? And so when I talk about potency, you'll find that the higher the potency, the less drug I need to get that effect there. So as an example, comparing morphine, it's a very good analgesic, used a lot in the hospitals, versus fentanyl. Usually used a little bit more in the surgical sort of setting. You're actually finding a lot of the heroin that people are turning to nowadays laced with fentanyl. But it's a very, very potent drug. So as an example, say you come in, you have a femur fracture, and I give you 5 milligrams of morphine, and equivalent a dose to that of fentanyl, maybe only 50 micrograms. Very, very potent in comparison. So again, it's important to know those equivalent dosages, so that way I don't accidentally give 5 milligrams of fentanyl, because that patient's going to stop breathing and they're going to die. Okay, so you got to be really careful in terms of how potent drugs are compared to one another. Now, again, when you're looking at drug references and you're pulling this stuff up, like they've already kind of figured out to some degree what the equipotent doses are. But I want to talk about this in terms of comparing and contrasting drugs together, so you at least get a feel for what it's like to see a drug that's like really, really potent. I don't have to give, say, micrograms of versus something that's not so potent. I may have to give grams of in some cases in order to get the desired effect. So this would be something we'll look at a little bit later on. And then efficacy is just what? How effective it is, right? How good a drug is at doing what it's supposed to do, right? So again, you're going to find that not all drugs are created equally. Some are more efficacious than others. So as an example, if I had that patient come in who had an open femur fracture, and I say, well, let me give you some Tylenol. they're probably going to say, no, 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 I need the morphine, please. This really hurts really bad, right? That's not going to be as efficacious of an analgesic as that morphine might be. So again, it's important to consider, well, how equally efficacious are these drugs, if at all, right? You may find that some of them work less well than others, as the case may be. We'll get into that. In general, you're going to find that efficacy is much more of an important determinant than the actual potency, right? So again, the patient doesn't really care how potent a drug is. They just care that they get enough of it to have the desired effect, right? Whether, in that case, to reduce pain, so that way they're not screaming because they can see their femur coming out of their leg, right? Anyway, other definitions, as I mentioned, equal potency would be when you get two drugs and you get the equivalent doses together, so that way they get the same effect. So as I mentioned in an example of equal potency, if I had 100 milligrams of drug A, an equivalent dose of drug B may be only 10 milligrams. Okay, and you're going to find that when you're looking up drug references, you're like, well, how come I have to give 25 milligrams of this drug, but I have to give like 2 grams of this drug to get the same effect? That's the equal potent dosage, right? It all goes back to how it interacts with the receptor and all that sort of thing. Now, again, clinically, you may not be thinking about that when you're prescribing drugs, but when you see the different dosages there, that's basically what they're figuring out for, right? They've already done the work for you, but I want you to understand, though, well, how come I have to give so much of this but so little of this? That's why, essentially. Okay, so getting into full agonists, those are going to be things when they interact with that receptor, they get 100% effect out of it. So if I say there's a full agonist, then obviously there must be also what? Partial agonists, absolutely. So you can have things that will bind to those receptors, maybe only get partial effect. So that example I mentioned of Suboxone, buprenorphine, if you are addicted to, say, heroin, that is your opioid du jour, and you're using it all the time, that's a very good full agonist at the opioid receptors. Well, what if I use buprenorphine, which is only a partial agonist? I get less effect. Hopefully I prevent withdrawal in those patients, but they are not going to turn back to that heroin potentially, right? So again, by using a partial agonist, I can wean them off of their opioids and eventually get them off of it entirely, okay? So partial agonism is a thing you have to consider as well. Full agonist, partial agonist, and then we'll obviously get into the antagonists in just a few minutes here. So, as I mentioned, it'll bind to the receptor. It binds just the same as a full agonist does. It just doesn't get the same full effect out of that receptor as you would see with a full agonist, okay? Even if you occupied every single receptor available, you'll still never get 100% effect because the drug just can't elicit that reaction out of that receptor, okay? So just one thing to note there, that your efficacy is never going to be as high as a full agonist, even if you got every single receptor hit there, okay? I'll show you a graph of that in just a second. But imagine if you had a partial agonist. Here you find the full agonist. You get 100% effect out of this receptor. Let's say this is an antihypertensive. And that full 100% effect, I get, say, a 10 millimeter mercury reduction in your systolic blood pressure. Versus if I were to give a partial agonist, maybe I only get a 5 millimeter mercury difference there. Okay. So again, same amount of receptors are occupied, but you're only getting a partial effect. So thus the efficacy is lesser than what the full agonist would be. Okay. And again, looking at partial versus full agonists here, you can see that the response that we get out of a patient is going to be on the y-axis. You're going to have concentration here on the x. The full agonist always is going to be more efficacious because, again, it's 100% activating those receptors there. Now, antagonists, you're going to find a lot of drugs fall into the antagonist category, meaning they will bind to that receptor, but they do not activate it. They don't do the opposite effect necessarily. They just block it and prevent other things from coming in and interacting with it. So as you might imagine, what's a neurotransmitter that can increase your heart rate? You have to think about it. Epinephrine is really good, right? So epinephrine increases your heart rate and interacts with the beta receptors on the heart. What if I give a beta blocker? That's an antagonist that's going to sit there on that beta receptor and prevent epinephrine from interacting with it because it's been occupied. That receptor's already been occupied by the beta blocker. Thus, heart rate should go down in that case, right? So again, keep in mind that this is where some students will have an issue or have a hard time with it, is that thinking about what are the opposite effects you're going to expect to see by using an antagonist versus an agonist, etc. And we'll get into those details later on. But just know that oftentimes what we are using are going to be competitive antagonists, meaning that it's kind of a numbers game between using the agonist versus the antagonist. So as an example, say for instance, I had a patient who's on a beta blocker, blocking those beta receptors. I can give enough epinephrine. So say they were coding or something, I can give them enough epinephrine to kick that beta blocker off the receptor and thus initiate normal activity at that receptor again. I just need a lot bigger dose in order for that to occur there. It's a competition between the number of the two, okay? So just as an example, anyone know what the reversal agent is for opioids like morphine or heroin? Yeah, a lot of people have heard of Narcan before, right? So Narcan is an antagonist. It's a competitive antagonist. So if I have someone who's overdosed on heroin, I can give them Narcan and that will then kick off that receptor. Sometimes you have so much opioids on board, I need to use a lot of Narcan because it's a competition between the two. It's a competitive antagonist, okay? Some cases will have what we call chemical antagonism, where you're going to find that you may actually bind to the agonist, So when we talk about things like monoclonal antibodies, we talk about antibodies we've actually produced in the lab in order to bind up certain things in the body. It's a chemical antagonism because they bind to and then inactivate them. Some cases here we'll have functional antagonism, where you're going to find that the medication we're using is blunting the effects within the body itself. So imagine if I had a patient who is I'm trying to think of a good example of this one. Imagine a patient had an insulinoma. Say they had a tumor that was producing too much insulin. I could give a drug called glucagon that will raise the blood sugar back up to combat that, right? They're physiologically at odds with one another, even though they don't interact at the same receptors. It's called much more of a functional antagonism. We'll talk about cases of that a little bit later on when we get to specific drug examples. But again, just note there's no activation of the receptor itself, okay? Again, just a picture kind of showing you what this would look like normally. Again, the normal ligand would bind to the receptor site, causing normal activity. By using the antagonist or using an agonist drug, you kind of get the same effect. But an antagonist is just going to block it up, right? It's basically like putting a seal on that receptor and preventing anything drug or otherwise from interacting with that receptor at that point. Okay. Now again, if I had enough of ligand or enough drug along, I could kick this off, and that's that competitive antagonism we were talking about there. Okay. Okay. Other things. So looking at in terms of the reversibility of some of these agonists and antagonists, you can have things that can be irreversible, meaning they cause a covalent bond to be formed with that receptor, and thus they are inactivated. So as a good example of this, we talked about ibuprofen being an NSAID. That's a reversible antagonist. As soon as that drug is out of the system, everything starts to work normal again, right? The normal inflammation is going to happen. Normally, your platelets are going to start to work normally again. Well, think about aspirin. What do you use aspirin for most often? Or prevent a heart attack, right? So aspirin is an irreversible antagonist of cyclooxygenase. We use it because it works on the platelets. Prevents platelets from aggregating together to cause a clot and causing a heart attack, right? And this is an irreversible agonist. So I can give, anyone know what like a normal dose for prevention of heart attack is for patients? So if they're having like an active heart attack, you give them 324. Or if you have like a headache or something, you take 324, 325. Just normal every single day dose. 81 milligrams, right? I give them a baby aspirin. Like, why am I giving a baby aspirin to an adult patient? Because I don't need that much, because it's an irreversible antagonist, right? Once it binds to that COX enzyme and those platelets, as long as that platelet's still around, it's always inhibited. You basically have to get rid of those platelets and produce new ones in order to get the same effect out of those platelets now, okay? That's considered an irreversible antagonist. That's a very good example of one of those, okay? Now, again, when you're comparing the activities of an agonist by itself versus an agonist plus a competitive antagonist, note here that you can overcome the antagonism effect. You just have to really jack up your dose and really increase it pretty significantly to get the same effects out of this. But just know that it's going to be a lot harder because now you have that antagonist on board preventing those the agonist from working. Okay. Okay, so as a practical example, again, I always like to talk about tox and opioids and drugs of abuse and all kind of stuff. I think students usually find it more interesting anyway. Now imagine if I had someone was taking an opioid, right? What kind of effects would you expect to see out of an opioid? What do we use it for normally? Pain most often, right? We use it as an analgesic, right? But a lot of people get some euphoria out of it, and so they get addicted to that feeling they get from all those little dopamine squirts that they're getting from that reward pathway, right? But anyway, so they get the euphoria, they like it a lot. They say, well, let me take, if a little bit was good, let me take a whole lot of it. And so then they get what we call the triad. They get this meiosis, they get the CNS depression, and respiratory depression. That's usually what ends up causing them to die, is that respiratory depression. So imagine I have a full agonist like methadone. You see here, I get full opioid effect out of that. Very good at causing good opioid effects. The partial agonist, buprenorphine, I'm only ever going to get a partial effect because, again, even if I occupy every single opioid receptor, it's only going to get partial effect out of that, okay? And then, say I wanted to reverse that patient, say I walk in and so-and-so's on the floor, not breathing, get my Narcan out, give him a shot of that, and then you're going to find you'll get no effect whatsoever because once that naloxone has knocked all of the opioid off of the receptor, now you lose that effect. So has anyone ever seen Narcan given to a patient before? What's it look like?
They wake up really. Usually they're pretty pissed off at you.
Mm-hmm.
And it's wide-eyed, really.
I equate it to The Exorcist, right? So again, you think about someone jumping right out of bed, and stuff works super quick. Like within a few seconds, patient's going to be up. They're going to be breathing, which is what you want them to do. But oftentimes, especially if they spend a lot of money on all those opioids and you reversed all of it, they're going to be not too happy with you, right? All of a sudden, their GI tract wakes up and they're going to be throwing up. They're in withdrawals. It's very, very stark when you see it. Hopefully, you don't get that much of a dose. I really just want them breathing. I don't need them awake, right? Your nurses are not going to appreciate you waking them up. But you're going to see that naloxone, because it's a full antagonist, it's going to knock all that stuff off, and the patient's going to wake up immediately. Okay, and again, you can look up videos of this. There's a movie called Taking Out the Dead, I believe, with Ving Rhames and Nicolas Cage. There's a scene there. Just look up Narcan bringing out the dead, and it's a very good representation. It's actually pretty true to life when you see that. But anyway, so again, that's the activity of an antagonist. It's going to knock all that drug off, and then you have normal activity of those receptors again. Okay, now getting into specificity, you're going to find that we have some drugs with very high specificity and some with very low specificity, meaning what type of, and what number and breadth of receptors is it really interacting with. Typically, we like to have things with very high sensitivity, right? Because I'm only going to get the desired clinical effect. I'm not going to get all the other side effects I'm really worried about. So as an example, looking at antibiotics. Now, antibiotics are used for what? To kill bacteria, right? That's what it's used for. Now, do I want antibiotics to kill our cells too? No, but they're selective enough to where they will target bacterial targets, but not human targets. Very selective, very nice, because again, I get limited side effects out of those medications. On the other hand, let's look at low specificity things. Let's look at things like chemotherapy drugs. Now, a lot of the old school chemo drugs, can they tell the difference between a cancerous cell and a non-cancerous cell? Frequently they cannot, which is why you see the alopecia, why you see the immunosuppression, why you see the GI effects, why you see all those nasty side effects. Like, it's basically poison you're giving these people to try to kill off all the cancerous cells, but keep the healthy ones to some degree, help them recover, and you do it all over again, right? You have to give multiple cycles of chemo to treat these patients. Very low specificity. Nowadays, we have better drugs. We have more specific drugs that only interact with certain types of targets. Help to mitigate a lot of toxicity, but again, the old school drugs we still use day in and day out are very non-specific, right? So again, high specificity is good because it limits a lot of the extra side effects you'll see there. Another good example is like the tricyclic antidepressants. Those are very low specificity. Back before we had SSRIs, we had to use things like amitriptyline or Elavil in order to treat depression. One of the most deadly drugs you can overdose on is going to be your TCAs. Okay. Now again, you're thinking, well, I have a depressed patient and I just gave him a really dangerous drug. Isn't that dangerous? Yeah, because again, one of the big things you'll find on any of your antidepressants, there's a big black box warning. You know what it says? Increased suicidality. We'll talk why that is later on, but again, it's one of those things where you have a very dangerous drug you're giving to patients who are now more prone to commit suicide. It causes a problem, right? Which is now it's nicer that we have more selective drugs like SSRIs. They only work on that serotonin receptor. They don't interact with all these other receptor types as well. Okay. So again, we'll get into those examples later on. You get a feel for that. We'll talk about those. Okay. All right, somebody going again here. Good, I'm glad you guys came back. I was worried. Everyone went to go drop out. So I cannot deal with this guy right now. All right, so anyway, so any questions from the first half? But next week we'll have the actual site open. You can use the sticky board and all of that. I apologize for that delay. I had no idea that was even a thing. Who knew you had different summer semesters? Not I. Anyway, so getting back into talking about these drugs here. So if you remember back to Orgo, you guys all took Orgo, right? Organic chemistry, absolutely. So you remember stereochemistry. It talks of enantiomers. Oh, I know some people are having like flashbacks. They're like, oh, PTSD flashbacks. No. So most drugs you'll find come in a racemic mixture. What does that mean? 50-50 between the left-handed and the right-handed side of the molecule, right? So again, typically, all drugs are going to come like that. However, there are some cases there where we can actually separate them out, because you'll find maybe the left-handed one has all the clinical effects, but the right-handed one has some of the side effects. And so by separating them out, then you get potentially a safer drug, right? Sometimes what you're going to find, though, is they'll do that just because they get a new patent out of it. We'll talk about patents in a second. And then they can now make a lot more money off of it by having a new brand name drug. Again, you may find that I have a little bit of cynicism with some of the topics we'll talk about. I don't want to jade any of you. I'll let you develop that naturally on your own, on rotation, so just let that take time. But anyway, so, as an example, if you are familiar with the drug albuterol, well, I can separate that out and just use the left-handed form, and now all of a sudden I get levalbuterol, right? So if you hear Xopenex, that's just the left-handed form. Now, one handy thing you'll note is that you can find equivalent doses of these drugs here, because again, if I have 5 milligrams of a racemic mixture, we said it's 50-50, right? That means 2.5 milligrams is the left-handed, 2.5 milligrams is the right-handed. So an equivalent dose of Xopenex compared to albuterol is 2.5 milligrams versus 5 milligrams. That makes sense for everyone?
Yeah.
Like the levalbuterol would be like the left-handed one. So albuterol itself is the racemic mixture. So anytime you see like a dextro in front of something, a lev in front of something, des, I'm trying to think des. Maybe not, but like dextro, anything like that, or that usually is indicating that it's an enantiomer, right? So as an example, citalopram versus S-citalopram, right? S-citalopram is the enantiomer of citalopram, right? They do the same thing. They have the same clinical effects, but escitalopram is now a new drug that they can market and use. So it's Lexapro versus Celexa, which is the racemic mixture. Now, again, where I find this comes up most commonly is that when you go to a hospital, do we have every single drug known to man available? No, it's not very economically viable, right? So we have a formulary. So we have a very selected set of drugs that we have. Well, sometimes patients will come on and come in the house, and they'll be on citalopram. Well, I don't have that available. Maybe I only have escitalopram available. And so I have to do a dose conversion to figure out what an equivalent dose would be. So as an example, if they were on, say, 40 milligrams of citalopram, and I only had escitalopram, well, I say, well, the equivalent dose would be 20 milligrams, right? So again, you're just taking half of that, or potentially doubling if you're going the other way. Cetirizine, everyone knows what cetirizine is. You can get that over the counter. It's Zyrtec. They have levocetirizine. Now, all of a sudden, that's a prescription product, right? It's behind the counter now. And again, what's interesting though, I found this ad one time and I thought it was very interesting, just because they say, look, wisely designed to be different, active enantiomer Zyrtec with no dextrocetirizine. You're like, wow, that sounds really good, right? So you look, the clinical relevance regarding the absence of dextrocetirizine is unknown. So you wisely designed it, but you have no idea if it actually does anything. Cool, right? So, but again, they get a new patent on it, they can make some more money off of it. So again, there's always usually financial, follow the money. You'll usually see why people make a lot of decisions they make. But anyway, yes, ma'am.
Is there like when you talk about those changes, is there something that always changes too? Like if a patient is like reacting to something, is there always an equivalent?
Not necessarily, right? So you may find there, there's a lot of different examples where you may find that there's not a good therapeutic equivalent to what they're on. Maybe you have to switch it to a different class of medications entirely. Sometimes you can stay within the same class. It just depends on the setting there. We'll talk about examples of that when it comes up. Yeah, for sure.
And for the dosing, is it always like equal potency levels?
When you make those conversions there, in general, you're going to find that holds true for the most part. So as an example, people have heard like the drug Nexium. It's like a proton pump inhibitor used for GERD symptoms. That's omeprazole. And you have esomeprazole, which is the enantiomer, right? So again, I can convert 20 milligrams of omeprazole to 10 milligrams of esomeprazole. In general, that holds true for the most part. Mm-hmm.
Just to be clear, do enantiomers usually have more efficacy than the racemic?
Not necessarily. Like, there's an example just there with that that levocetirizine. They said we have no idea if it works any better, but they can take it into the FDA and be like, look, I have a brand new drug. And look, we have all this information on the racemic mixture, so it's got to be safe, right? And so they market that, and I have a new patent, right? So, again, it's one of those things where sometimes, yes, there is clear benefit. Oftentimes, there may not be, okay? So just be aware. We'll talk about those examples as they crop up there, okay? Anyway, so getting into a few more definitions, one term we have is called downregulation. Now, normally, the body likes to maintain homeostasis, right? So, again, if you get cold, what does your body do to warm itself up? Start to shiver. If you get hot, what does the body do to try to cool down? You sweat, or you take some clothes off, or whatever the case may be. Your body wants to maintain homeostasis, and with drugs, there's no difference there, right? So as an example, if I have an agonist that is constantly hammering on some receptors that normally would not be activated quite so much, what do you think the body wants to do to counteract that? Well, it can reduce the number of receptors that are available. So basically, by decreasing that number there, you get less effect out of that. And so you find this very frequently in the body where you may start a drug and you may say, wow, I get really good effects out of this, but over time, they tend to diminish. And some of that is related to the receptor regulation that's happening there. If I'm giving an agonist that's activating the receptors too much, they will downregulate. Now, conversely to that, what if I were to give an antagonist and I'm blocking those receptors and say, hey, I'm not being activated enough, what's it going to do? It will then upregulate. You'll have more receptors that are available, right? I'll talk about a few examples where that's clinically important in just a little bit. But again, you're going to find that downregulation occurs with agonists, upregulation occurs with antagonists, right? Because again, the whole goal here is to try to maintain homeostasis and get back to what that patient considers to be normal, so to speak. So some other terms here, bioavailability. Now basically this means the percentage of drug that gets absorbed via a given route of administration. We'll talk about routes of administration in a second here, but this varies greatly depending on the route that you use. So as an example, if I give a drug IV, if I place it directly into the veins, 100% of that drug is now in your system. That's 100% bioavailable, okay? Now what if I were to say give it via the oral route? and I were to give it in the oral route, and say the stomach enzymes start to break down a little bit, and then the liver breaks up a little bit before it actually gets into the bloodstream. Maybe it's only 50% bioavailable. Maybe you've lost some of that drug. Maybe it's only 10%, or maybe 0%. You're going to find that it ranges pretty greatly depending on the route of administration, and we'll cover those in just a few minutes here. Just know IV is always going to be 100%, but everything else can be a little bit lower than that, as you'll see. Now, to go along with that, we have what we call the first pass effect. That basically equate to be the liver tax, right? So this is when you take a drug orally, it's going to get absorbed, not usually in the stomach. Most drugs do not get absorbed in the stomach. They will get into the small intestine and then be absorbed from there. There's going to be some amount of that drug potentially that gets metabolized both in the actual stomach lining or the intestinal lining itself. There's some enzymes there. But then what's the first organ that is going to be hit after it gets absorbed from the GI tract? Which is the liver, right? So again, everything kind of gets through, it gets absorbed from the GI tract, hits the liver first, and then gets absorbed to the systemic circulation in general. So some of those drugs are going to get metabolized in the liver. That's one of the main functions that we'll talk about with the liver is its activity on drugs and metabolizing them. And so again, you may find that some drugs have extensive first pass effect, meaning that I am able to get no absorption whatsoever, and I cannot give that drug orally. Some cases it may be 0%, right? The drug passes through with no problem whatsoever, okay? It can range pretty greatly. And that also can give you a clue as to why different drugs will require different dosages with different routes. So as an example, a beta blocker called propranolol may only have to give, say, 10 milligrams IV. The equivalent dose PO or by mouth is going to be, say, 40 milligrams, right? Because of that first pass effect, the liver is metabolizing a lot of that. Only 10 milligrams of the oral dose actually gets through. And again, we'll talk about actual examples of that when we get to the specific drugs, but just know first pass effect is going to greatly affect how much of that drug gets absorbed and how bioavailable it's going to be. Okay. Anyway, some other things to mention here with first pass effect is called prodrugs. Now, prodrugs is not the same as like, you get prodrugs and like amateur drugs. Like prodrugs are the really good ones, right? Not like that. Prodrugs just means it is an inactive drug until it gets metabolized in the liver and becomes activated. Okay. So as an example of this one, there's a drug called lisdexamfetamine or Vyvanse. Have you ever heard of Vyvanse before? It's an amphetamine we use for ADHD. Okay, it's a pretty popular one. And what some people would used to do, or they probably still do, say you take like an Adderall or something like that, you could crush it up and then you could snort it, and you actually get a pretty good high off of that, right? So a lot of people do that. What these people decided to do with Vyvanse, they said, well, let's do a prodrug. So this way, they try to snort it, it doesn't hit the liver to a big extent, and then it never gets activated, so they get no high off of it. But when they take it orally, it gets absorbed, goes to the liver, gets broken down to the active form, which is the dextroamphetamine, and then it has its normal clinical effect. So initially, this was used as an abuse deterrent to try to prevent people from using it incorrectly by using a prodrug. But we have lots of things that are prodrugs. They're inactive in their normal state, but then once they hit the liver, they'll then become activated. Okay, so like ACE inhibitors, which are common antihypertensives, and other drugs like that, you'll find are considered to be prodrugs. Okay. Another term we'll talk about in terms of kinetics is called volume of distribution. Now, normally when I'm talking about drugs, where they go from the body, so in our example, we said we gave a drug orally, gets absorbed from the GI tract, goes to the liver, and then eventually hits the systemic circulation, right? So again, that's just mainly in the bloodstream. From there, where do drugs go? Well, they distribute all throughout the body. And so when we're talking about how extensively does it distribute, how far out does it go? Does it like to really stay in the fat tissue? Does it like to go into the brain? Or does it like to stay there within the bloodstream? Is in terms of how much distribution actually happens with that drug. And so we call that the volume of distribution, how far distributed out it gets. We'll talk much more about this later on in the pharmacokinetics section, but just kind of keep this in the back of your mind that not all drugs just stay there in the bloodstream. They have to get to their site of action, and so that distribution is going to be an important process we'll talk about. Okay. All right. Any questions so far on the definitions? Everyone feel pretty okay so far?
Good question about prodrugs.
Yeah.
So if it's being metabolized longer in the liver, would that cause more toxicity in the liver at all?
Not necessarily. So just because things are metabolized in the liver does not mean it's causing any damage to the liver. That's just what the liver does. Like it's just basically is where it metabolize a ton of byproducts in the body. A lot of other effects that it does too on cholesterol and glucose and things like that. But the liver is one of its main jobs is to get rid of toxins, and so that's one of the things it's doing there. So yeah, not necessarily. Some drugs have inherent hepatotoxic effects, but a lot of them do not. So it just depends on the case there. Anyway, yes, ma'am.
Would you be going over what the liver does to activate it?
Oh yeah. Oh yes, don't you worry. We will get there. This is just the intro, right? So yeah, once we get to the kinetics section, you'll see there's a lot of details on specifically what that liver is doing. We'll talk about all the enzyme systems, and you're going to learn to hate the P450 system. It's going to be great. Just wait. Yeah, just give it time. Yeah. Anyway, so let's talk about routes of administration. How do we get drugs into patients themselves, right? So we have a lot of different routes that are available here. And so this table is good because it gives you a general overview of the bioavailability in general terms. It talks about some of the characteristics here. Don't memorize the numbers, so to speak, but just have a general feel for, okay, well, how does the bioavailability of an IV dose compare to, say, that of an oral dose versus, say, an IM dose, okay? Again, if I mention any like acronyms or any abbreviations and you don't understand, just let me know, and I usually try to specify what those are, but if I forget one time, just let me know. But everyone knows PO is by mouth, SL, sublingual, IV, intravenous, IM, muscular. How about PR? Per rectum. Yep, good. All right, so you guys have a pretty general feel for this. Again, just note that IV is the only one that's guaranteed to have 100% because, again, I'm putting it directly into the veins, already in the circulation. Okay. So let's talk about them individually. So again, IV is the most direct means of doing this, right? Very fast onset, right? So the route has a big effect on how quickly drugs work. IV is typically one of the fastest ways for these to kick in. The other thing, too, is this also can be titratable. So as an example, when I say if I give a drug intermittently, do we know what that means versus continuously? Yeah, so if I'm giving it, say, every 12 hours, that would be intermittent dosing, right? Versus if I were to give a continuous infusion, that means I'm giving the drug continuously, right? So again, imagine having a patient who has low blood pressure, and I want to get their blood pressure up. I can give them a continuous infusion of epinephrine. As I'm infusing that, I see the blood pressure come up, and I say, okay, things look good. Say the pressure gets too high. What do? I dial down the epinephrine. Now the blood pressure comes down. Now it's too low. I dial it back up. That's titratable, right? So I can make sure I can get right within the frame I'm looking for in terms of the efficacy. Okay, we do that for sedation meds. We do that for all kinds of cardiac meds. We do that quite a bit. Yeah, we'll talk about epidurals in just a second here, but very similar. Yeah, we can titrate those doses there. Again, 100% bioavailability. Also, another thing to consider is where are you actually placing the medication within the veins itself. So we talk about central versus peripheral access. Peripheral access, what do you think that means? Using it in the extremities, right? So if I have like an AC, it's placed, right? If I'm placing a vein here, that's a peripheral vein. There can be some issues there, right? You can have what we call extravasation. That means you're getting drug going, say you blow that vein and drug is being infused outside of that vein into the surrounding tissue. That can cause a lot of damage, right? So here's an example. Someone who has purple glove syndrome, that tissue is all necrotic now because that drug extravasated out into the tissue. It's an anti-epileptic drug or anti-seizure drug called phenytoin, and that person may have to have that amputated. They may sue. I mean, there's lots of issues that can come about with improper administration of these drugs. So we said, well, if we have a drug that's really hard on the veins or if it's likely to cause this kind of really bad extravasation, well, is there any safer way to give that? And that's where we get into central access. In central access, that basically means we have a long catheter that gets put, either maybe like an ephemeral vein or maybe may have an implanted port. Basically, it just means that there's a catheter that's going to empty out into the vena cava. Now, what is the benefit of doing that, you think? I didn't say faster delivery so much, but there's a lot more volume, right? So as opposed to the volume that's in peripheral vein, all that blood coming right back to the right side of the heart is right there. So it dilutes out things very quickly. It means it's going to be easier, and again, you're less likely to have that extravasation occur there. So when we say central access, it just means that we're able to give maybe higher concentrations of drugs. We're able to give certain drugs are preferred via the central access, and that's what we're talking about with that. Okay. Yeah, so what does PICC line stand for? Anyone know? Peripherally inserted central catheter. So again, that would be something that gets placed peripherally, and then we would have that catheter go all the way to the vena cava there. Right, absolutely. It's also nice you can get like multiple lumens there. So if you're like a triple lumen or a double lumen catheter, again, you can apply drugs at the same time. And again, they dilute out so quickly you don't have to worry about like issues with that. So it's a very nice way to give it. However, there are risks associated with that, right? Anytime you have a piece of foreign material in your patient, what are you at risk for? Infection, right? That's why you worry about like PICC lines getting infected. Then you all of a sudden have a bloodstream infection. It's no good, right? The same thing can happen with the peripheral line, but central lines, because they are again so deep, that's a big concern. Anyway, disadvantages of the IV route. Once it's in the system, guess what? It's there. You can't really do anything about it once it's in that central circulation. So be very careful when you're administering that. Other cases, you can have precipitation of substances. This is why we don't like to mix drugs very frequently, because sometimes they're insoluble together. What happens if they crystallize out? Well, they can potentially cause an embolus in the lungs. They can cause, to lose that potential IV access. So you gotta be careful when you're mixing and matching drugs together. Not typically a big concern from you, but certainly our nursing colleagues, when they're trying to give medications together, I get this all the time where a nurse will call me up and say, hey, listen, I only got 2 lines. Can I run these 2 drugs together because the other one's got something else running? I can't stop that. I'm going to apply these 2 drugs. Can I do that? And we worry about the solubility. We worry about the compatibility there. And so that's one thing to consider there. Anyway, so that's IV. Again, very standard. Much more on the inpatient side of things. You're going to see this being used. Now, what happens if you can't get a vein? Now, what kind of patients do you think will be difficult to get IV access on? So the extremes of age, typically, right? So either the very old patients, especially if they're like intravascularly depleted, like they're dehydrated, very hard to get a vein. Very little ones too, right? Imagine if we have some NICU patients in our NICU right now that are 600 grams, super tiny, 23 weekers, right? Very, very tiny little things. It can be very hard to get IV access because those veins are so small, they're so delicate. It can be very hard. So what could we do instead? Is there any other ways to do it to get IV access? And this is where intraosseous access actually comes into play here. And so this is where we'd actually use a needle to go through the bone into the marrow. Now you have a nice big non-compressible vein. It's very easy to give all kinds of medications and fluids through. Very, very good. We use this a lot in emergency settings. So if you ever see someone come in, paramedics may place these. They may place them in the ER. We use them all, quite frequently when we cannot get an IV placed there, right? So again, usually you get this easy IO, which is like a little power drill, and then you'll have these little thumbtack looking things that will get drilled into the patient.
That's very painful, probably, right?
Actually, from what I've heard, I've never had one, so I can't speak to it personally. If you do it correctly, it's not that much more painful than a normal IV. So that's what I've heard, at least. But it appears pretty gruesome, though, right? And so, I mean, you can go through the humerus, you can go through the sternum. The tibia is probably the most common one you're going to see there. So there's different places. But the thing is if it comes down to, well, is it going to be painful? Is that patient going to die? Yeah. So you give it anyway. So, but again, just to give you an idea of different ways we can get IV access without actually having to go through a vein, so to speak. Okay, next we have sub-Q administration here. This is good for either like slow releasing implants. So for instance, we have certain types of birth control. That drug I talked about, Suboxone or buprenorphine, there's actually implantable versions of that where patients will have that kind of slowly absorbing over time. We can do this especially for self-administration, right? It'd be very difficult for a patient to start their own IV. Actually, don't recommend that. However, they can definitely give themselves a sub-Q shot with some training there. So it's very good for people using insulin. They're taking certain anticoagulants at home, things like that. It's pretty bioavailable, but it's slow in action, right? It's not going to be quite as quick because it's not going right into the veins. That's one thing to note there. And just note, can be painful, especially having to inject yourselves over and over again. Really important that patients rotate sites. They don't use the same spot every single time because eventually you can have fibrosis of that tissue there. You can get some issues with that. And again, using an anticoagulant, anticoagulants cause what? Bleeding. So again, you get that local reactions you can see with that. So again, it may not be preferable from a cosmetic sort of standpoint. You don't want to, summertime, you don't want to go out to the beach and have a bunch of, little hematomas there. So.
Insulin pumps, do they work like that?
Yeah, insulin pumps will also be, so basically we'll have a sub-Q catheter that gets placed, and that'll have the same effect essentially. Yep. Next we have IM administration here. Again, less invasive than an IV. Pretty easy to get access to the muscle there. A lot of different muscles we can use. The deltoid. Don't use the gluteal muscle quite so much anymore, but can be pretty painful. Frequently, how we'll use this is if we have a patient, say, for instance, I have a kid who comes into the ER and they're not able to tolerate, PO. Can't take anything by mouth, and say, for instance, we can't get an IV on them, we can use IM administration of certain medications. You have to think about the volume that you're administering here, right? Sub-Q space, you can do a lot of volume. That's no big issue there, right? Because again, you can have some expansion of that tissue, no big deal. IM administration, you have to be careful with the volume because once you start to expand that muscle out, it gets pretty painful pretty quickly. And so especially with little kids, we have to be considerate of how much we're actually giving in terms of just the volume itself. So usually more concentrated drugs get used. Typically we don't like to give any more than 3 mLs, which again, depending on the drug, you may not be able to get a whole lot of that drug, right? Because there are limitations how concentrated things can get. But it's important you have to have good blood flow to the area. So if not, you're not going to absorb the drug very well. So if a patient's hypotensive and they're not perfusing the muscles well, that's not going to work too good. And then you have to worry about things like, either obese patients or emaciated patients, the extremes of weights. may have a hard time absorbing as well, depending on the case there. But again, very good administration site if you do not have IV access. Again, the vastus lateralis, deltoid, probably the more common ones you're going to see being used there as well. Okay. Next we have intrathecal. So this is again, and you guys have ever heard parenteral versus enteral routes of administration? Parenteral means anything that is being given via needle, essentially, right? So again, when I talk about IV, IM, sub-Q, intrathecal, these are parenteral routes. When I say enteral, that just means what? Via the GI tract, okay? So that's kind of the big delineation between those. You may hear things about parenteral versus enteral nutrition. Same thing, right? I can give nutrition via the IV, or I can give it via the mouth. And so we'll again make that delineation hold true. Now, intrathecal routes of administration are very good because this actually goes across the blood-brain barrier. Normally, the brain likes to keep stuff out if whatever possible. It's very protective of what gets to the brain. Well, what if I give the medication directly into that space there? And so we can give this intrathecally. Now, again, when you think about intrathecal drugs, what do you normally think about? The epidurals for labor, right? Because, again, labor is a very painful process, as I hear it. Never experienced it myself, fortunately, but I hear it's very painful, right? We can do it with other drugs, though. You can do things like chemotherapeutics. You can do it for antibiotics, potentially. But probably the one you think about most is LND, labor and delivery. Think about this being used for labor-induced pain. Placement's really important here. This is why usually you have like a CRNA or an anesthesiologist placing this, because, again, you worry about placing it incorrectly. You may not be getting the drug actually into the intrathecal space. You can screw up all kinds of stuff. So that's why it's very important to make sure that procedure is done appropriately. Also, sterilely. Because again, what happens if you introduce bacteria into a kind of protected site? Not good, right? You don't want to do that.
It actually happened to me that one leg was paralyzed and the other one wasn't.
Yeah, and so a lot of it has to do with placement of the patient as well, because again, depending on how high up the spinal column it gets, will dictate how well the drug is working. So usually, when you have like a epidural being placed for labor, it's a mixture of a local anesthetic and usually an opioid like fentanyl. And so depending on how high up it gets in placement of the patient, you may find that you can have varying degrees of anesthesia happening there, up to you can't move your legs at all. Frequently, my wife would complain that she was going to hop up and kill me during the labor process. When I said, you have too much medication on board, you couldn't stand up anyway, so I think I'm safe over here on the side of the room.
Then 2 days later.
She didn't appreciate that. Yeah, no. I remember, you can still see systemic effects from this. I remember, one of the big things you can find is hypotension can develop from using this. And so I remember telling my wife, I was like, your blood pressure looks a little marginal there. Like, maybe we should need to dial down the medication a little bit. She said, if you do that, I'll make sure this is the last day you live on this earth. I said, okay, we'll leave your dose exactly where it's at. It's totally fine. Yeah, but we're talking about just the continuous infusion of it, right? So that's one of those things where it's a patient-controlled analgesia, where we can dial in the dose or give yourself an actual bolus dose. Yeah, so she's sitting there just. Anyway, okay, so moving on over to the enteral route of administration, we have things like sublingual. This is good for drugs that maybe have a high first pass effect, or if they were taken orally and they were going through the small intestine and then absorbed by the liver, they get metabolized too much. That first pass effect is too high. So by giving something sublingually, it gets absorbed right there and goes basically to the systemic circulation. You kind of bypass the liver. Okay. As an example of this, this is also good for patients who cannot tolerate anything orally. They don't want to swallow things. So imagine if you have someone who's going to the ER because they're having a lot of nausea, vomiting. Give them a sublingual dose of Zofran on Dansatron, and that will absorb just fine from the sublingual space. Okay. Again, the idea of swallowing something may cause them to be nauseous and throw up again. One example. Very few drugs are used sublingually, so just be aware of that, but it is a route. If you ever see an ODT, that stands for oral disintegrating tablet. Those are usually your sublingual medications there. Next we have the oral route. Now again, this is the most common one you're going to run into. It's the most economical. It is the most safe in terms of administration itself. However, it requires patients to be compliant. So imagine if I have like a big capsule or a big tablet and I say, here you go, 2-year-old, take this. What are they going to say? They're going to say, no, I can't. They're not going to do that, right? So you tend to find that we have to have different formulations available depending on the patient we're dealing with. So like for pediatrics, we have a lot of liquid medications that we use, right? So again, it depends on how long that drug is good for. So if you imagine like getting antibiotics for a young kid, how long is that drug actually good for? For tablets, it's good for a long time, right? Versus liquids may only be 2 weeks or something like that. Also, think about the first pass effect. So again, some drugs may not be given orally because the first pass is so high. You can't really absorb very much of it. You got to think about things like drug interactions, not only with other drugs, but also with food. So as an example, you have a patient who say you give a fluoroquinolone to, which is an antibiotic. So you give some Cipro or some Levaquin to a patient. Say they come in, they have a pneumonia, you're giving them Levaquin, and they come back, a couple days later, and they're like, man, I'm still feeling terrible. Like I still got this fever. What's going on? Ask them how they're taking their medication, because one thing to know with the fluoroquinolones, if they interact with calcium, they bind up, and then you never absorb it. So if you have an older patient who drinks a lot of milk because they have osteoporosis, guess what? That drug never gets absorbed. So you could incorrectly say that, well, maybe the bacteria are resistant, and actually the drug never got absorbed in the first place to work, right? So these are little things you have to think about when you're playing detective, see why the drug's not working like they should. Other things to note, sometimes you'll find that drugs may have enteric coatings. This allows them to survive the acidic environment of the stomach until they can get into the small intestine. Normally the pH of the small intestine is a lot higher because you have a lot of bicarb being secreted and whatnot, and so you tend to find that they will then dissolve off, and then you can absorb the drug. So if you ever see enteric coated, that's what they're talking about. Like enteric coated aspirin is a good example of that. You may also find that drugs are in an extended release or sustained release. If you ever see like an XL or an SR or anything like that after a drug's name, that typically means it's a long-acting sort of medication. Okay, that means you can't crush it, you can't chew it, because if you break that compound, the way it's formulated is it's designed to go throughout the GI tract and releasing throughout the day. So you don't want to mess that up by chewing it or crushing it, things like that. But what do you think the benefit of is using a long-acting medication versus a short-acting one? Better compliance. That is the name of the game here, right? Because when you're giving patients chronic medications, they're supposed to be taking every single day. If they say, here, take these 3 tablets 4 times a day. I'm a pharmacist. I can barely take a multivitamin 1 time a day. So expecting patients, especially older patients, have cognitive decline, have memory issues, expecting them to have these really complicated regimens is really tough. That's why you like to combine meds whenever possible. So use combo drugs, long-acting meds, so that way you get the total pill burden down for the day. They can take one time a day. It's much more beneficial. And I mean, some of these older patients, they can have 15, 20 meds potentially, given all their disease states. So it's really, really important to think about the compliance standpoint and what they're actually going to do. Because again, if you ask a patient, they come up to you, you prescribe them a whole bunch of medications, and you say, hey, are you taking everything like you're supposed to? And they're really not. What are they going to tell you? Of course I'm taking it. Yeah, of course, right? So they worry about the shame they're going to get from you guys when you scold them for not taking the medications like you prescribed, right? So think about the compliance, right? Make sure you're trying to make it as easy as possible for the patients. We also have the rectal route, so the PR route here. This is good when patients cannot take PO medications. You'll find that this really bypasses a lot of the first pass effects, so you get pretty good bioavailability out of this. Probably the more frequent ones you're going to see here are going to be things like acetaminophen suppositories. You also find a lot of like enemas and other laxatives to try to stimulate defecation are given via the rectal route. Pretty common there. One thing to note, please make sure patients take off the foil wrapping first. Otherwise, it is pretty painful from what I hear. But typically, it'll come in this kind of cocoa butter sort of formulation where once it gets into the rectal cavity, it'll then melt and then allow it to be absorbed there, right? So you have to think about things like, well, what happens if the patient expels it too early? Well, the drug's not going to absorb it very well. So, for instance, if I'm giving Tylenol suppository to an infant, sometimes you got to hold the cheek shut, right? Because you know that they're going to potentially spit it back out at you. Okay, so little things to consider there. Usually for little kids, they don't really mind rectally administered drugs, especially like little babies. They can't really fight you too much on that stuff. But imagine like you talk to like an adolescent. I always see this in the ER. You'll have like a 16-year-old, female or male come in complaining of abdominal pain, and you find out they're constipated, and the doctor will be like, well, let me give you an enema. It's kind of embarrassing, right? Like it's kind of not too much fun, but sometimes that's exactly what they need. So always think about the compliance aspects of things, and we'll get into more of that when we talk about the GI drugs later. But anyway, next we have inhalation. So again, this is going to be nice because it gets applied directly where the drug is needed. Okay, so for instance, if I have asthma, I don't have to give an oral med that affects the entire body. I just want to affect the lungs. And so this is a good targeted way to just interact with the tissues that I'm interested in. So more often than not, you'll find a lot of asthma medications are given via this route. That's the most common thing you're going to find, by like COPD meds, things like that. Also, just note that this can have really good absorption for other things. So if you're familiar with anyone or patients who smoke crack cocaine, it's a very addictive substance, and it is absorbed very quickly via the inhaled route. So like where I did my training was up in Jacksonville, 8th Street, downtown Duval County. Like there's a lot of crack cocaine out there. A lot of patients showing up with crack chest pain, getting arrested by the police for having crack. But you saw a very good absorption of that, and because of that, it's very, very addictive. Again, we can talk more about that later on. But Anyway, some of the disadvantages, though, is that this is really entirely dependent on patient technique. If they are not using it correctly, you're going to find they don't absorb any of the drug, okay? I'll show you an example of that in just a second here. But technique is super key. This is where, like, your respiratory therapists are your best friends because they can do really good intensive training with them, talk about using things like valve holding chambers and things like that. So just be aware. There's also different dosage forms that are out there. So as an example, you can have things like metered dose inhalers. This is an example of this one right here. Now this is also bad technique. You probably don't want to be spraying your albuterol that far away. But this is a metered dose inhaler. Every dose has every spray has a specific dose associated with it. But you may also find things like dry powder inhalers, where basically it's a dry powder the patient has to inhale themselves, so they're kind of providing the inhalational force versus this, which actually has a propellant in it that will spray it out. And then there's also a nebulizer. I'm familiar with a nebulizer. This is a machine that will then has a compressor on it that will basically cause the liquid medication to be nebulized into a very fine mist, and the patient will then breathe that in. So a lot of different ways for that to work.
For kids, for asthmatic patients, for example.
Yeah, we can do it for kids who may not be compliant with this sort of technique here, or for like older patients if they have a hard time. Say, imagine an older patient with rheumatoid arthritis and their joints are just not what they used to be, and they may not be able to get the med there. That's one thing to think about. Here's an example of poor patient use. That's why the teach back method is so good. That's basically like, how do you use your medications? And they can show you something like that, and you're like, oh, okay, this explains why they're in the ER, 3 times a month for asthma exacerbations, right? So again, technique is super, super important for inhalational meds. If they can't coordinate well, if they don't have the right tools, it can be very ineffective, as the case may be. Anyway, some other routes we have include transdermal. So this is a means of giving a drug. You'll hear me talk about topical meds and transdermal medications. The difference here is that transdermal medications are intended to be absorbed through the skin to get into the systemic circulation, so that way they affect the entire body. This is good for patients who can't take oral medications, or they're also good for patients if you want to give something only, say, once every week or once every few days. It's good for like a patient with memory impairment and things like that. And so basically you have a lot of drug in the you have a whole lot of drug here in this patch, and then it'll be absorbed just based on passive diffusion. We'll talk about that process a little bit later on. But again, the advantage here, good patient compliance. You just slap a patch on, and you don't have to think about it for a couple of days. And it depends on the drug you're using there. Not every drug can go through the skin. So again, there's limits how many of these different drugs you can use here. Shouldn't use it on open wounds. And then also, this is a big deal as far as risk for poisoning, because you're going to find that even when you throw these in the trash, they have a lot of drug left over. And if a kid gets into that, that can be very dangerous for them, right? I've had a couple of cases of clonidine patches and fentanyl patches and things like that, kids getting into it, and it's pretty bad. Now, it compares with topical medications. That means something I'm applying to the skin to work locally, right? So if I apply hydrocortisone cream to an area that is very itchy and some dermatitis, that is a topical treatment, right? Versus something that would be transdermal, which is meant to affect the entire body. Other routes we'll talk about when we get to those specific sections. So we'll talk about the ophthalmic meds and oral meds and things like that later on. When we get to OB-GYN, we'll talk about the meds that can be applied vaginally, things like that. So we'll get to those as we need to. Okay, so any questions on routes of administration? Who knew there were so many routes, right? A lot of different ways to skin the cat, so to speak. But it's good to know the pros, the cons, and the relative bioavailability and onset of action. That's kind of the takeaways I think you should get away from that section there. Okay. How do drugs get out on the market? Anyone know? You've heard like clinical trials, like phase 1, phase 2, phase 3 trial. Have you guys ever been in a drug trial? Has any of you ever taken a medication before? If you have, technically you're in a trial. We'll talk about that in a second. Anyway, so the Food and Drug Administration are the people that will mediate this stuff, right? So again, keep in mind this does not include dietary supplements. That is a whole separate thing, right? So they're not going to be directly regulated by the FDA. Now, again, I'm not going to be the person who comes in and says, like, herbal supplements are no good. You don't ever use them. Don't ever recommend them. That's nonsense, right? They can be very powerful substances. It's just they're not regulated as tightly as these medicinal products are through the FDA. So just be aware of that. We can talk about that later on. But this is their whole purpose here, is they're making sure that the food, the drug, and the cosmetics you're eating hold of are safe to use. Typically what happens is that you'll have research scientists who will come up with a candidate molecule and say, hey, I think this would be a really good antihypertensive drug. And so they'll come up with a compound here. And again, looking at the time frame here, I want you to notice the full scale is about 20 years or so. So at a certain point, they'll try it on animal testing. They'll see how it works on mice and monkeys and all kinds of stuff like that. And then eventually the company says, okay, well, we think we have a good candidate molecule. We would like to try this in people. So what they'll do is they'll take an application to the FDA and say, hey, we want to try this drug out in people, okay? And so they'll have 3 phases of trials initially, okay? Basically, they'll start off in phase 1, and if you think about the number of people that they're giving this drug to, it may be like in the dozens, maybe less than 100 for a phase 1 trial. And basically what they're trying to find out is the drug safe? And they're also doing studies to find out what are the kinetics of the drug, like what's the half-life? How long does it stick around for? How does it get metabolized? Because again, can you extrapolate one-to-one animal data to people? Not in general, right? Some of your patients may act like animals, but it doesn't mean they are animals, right? I guess technically we're all animals, but you may find that monkeys don't act the same way that people do in terms of metabolism or distribution of drugs. So that's phase 1, right? Notice you're not giving it to people with the disease state in question. So you're giving it to healthy people to see how the drug works in them. Okay. Moving on to phase 2, now you're going to find, well, does it actually work in people? So maybe you're giving it to a few hundred patients now that actually have the disease state you're interested in. So they're giving it to hypertensive patients to see does this bring their blood pressure down, or giving it to diabetic patients to see does it make their blood sugar come down. Okay. And then finally you go to phase 3 where maybe you have several hundred, maybe several thousand patients are getting this finally. Again, they have the disease state. Say, well, does it work? And again, I'm not going to go into all the research behind it, all the biostatistics. You'll get that in another course. But basically, this is the largest phase trial. And say, okay, well, do we really think this works? They'll compare it with placebo. They'll compare it with other drugs that may be used to treat the same disease state to see, hey, is this even worth selling? Once they do that, they'll take all that data and they'll take it to the FDA and they say, hey, can we get approval for this? And the FDA will say yay or nay. If they say yay, then the drug gets put onto the market. Okay. From there on, and again, like I mentioned, we're only maybe giving these drugs to maybe thousands of patients here. What if you have a drug that has like a side effect that only happens 1 in a million patients? Do you think we would have found it in the phase 3 trials? Unlikely, right? Which is why you may have drugs that get put onto the market, and why every drug you ever take, you're a willing participant in that phase 4 trial, because if there is something that happens 1 in a million, we don't know about it until we give it to millions of patients, okay? So there's a good example of this. There's a set of drugs called the COX-2 inhibitors. They're kind of closely related to things like ibuprofen, but they were touted as like, oh, this is great because it doesn't cause any GI toxicity. It's fantastic. Worked kind of in a unique kind of way. And they were giving it to millions of patients. It's a big blockbuster medication. They were giving it to millions of people, making tons of money, hand over fist. And all of a sudden they realized, oh, wait a second. They actually do the analysis. More of these people are dying from heart attacks and strokes than people who are not receiving the med. Oops, right? So they looked at it and said, well, this is a big enough risk that we should take it off the market. So that's why you find drugs that may be on the market get taken off, because they find things that once they start to give to millions of people out there, okay? And so we have reporting mechanisms here. So if you have a patient who develops a new adverse effect to a drug, we can report that. We can track those sorts of things, okay? So the thing to note is that whenever they apply for the initial drug investigation, they only have 20 years in order to make their money back on that. So if it takes them 15 years to get a drug out in the market, they have 5 years where they can sell it as a brand name drug, and they're the only people that can make it. Once that 20-year period expires, now all of a sudden, that's when you have generic manufacturers that can come in and they can make their own varieties, which is why if you go look at Tylenol, there's a million different manufacturers of it, or acetaminophen, I should say, even though there's only one brand that makes Tylenol, so to speak. Okay. Now, to show, and you have some patients who will be like, well, the generics, it doesn't work for me. In general, the generics are supposed to work just as well as the brand names, right? And again, part of my responsibility as a pharmacist is to make sure I'm giving good, cost-effective care and giving them the cheapest variety of drugs available. But some people say, oh, only the brand name works. Generally, that's not true, because you're going to find that they have to show, the generic manufacturers have to show that it works just as well in order to show that they're bioequivalent, meaning that they have the same characteristics as the actual parent drug itself. So as a graph here, here's an antidepressant drug called bupropion comparing the brand name versus a generic manufacturer. And they have to show that basically the kinetics of it are almost exactly the same. And once they show that, then the FDA will say, okay, well, you're approved to be a generic manufacturer, and then they can sell that. Now, there may be a little bit of variation there. You may find that things like the shape of the tablet, the color of it, things like that can change. But in general, the drug should work exactly the same. Now, again, sometimes you have patients that only want the blue oxycodone, because that sells a little bit more on the street, right? Sometimes you see that. Sometimes people will have a bad reaction to other things in that tablet, because again, when you get a tablet, is it just pure drug? No, there's other things. There's talc in it, there's colorings, there's stabilizers, all kinds of different things. They may have a bad reaction to that, so that's something to consider. But in general, generic should work just as well as the brands. And so, in fact, if you, as a provider, write for a brand name drug, I have the ability to sub it out to a generic carte blanche, unless you write very specifically, only dispense a brand. Okay, so one thing to note with that. Anyway, let's see here. So I got a few more minutes. We keep going, another 10. So let's talk about receptor signaling. Let's talk about how we actually communicate within the body in terms of receptors and how they're going to be interacting with drugs and things like that. As I mentioned, receptors are the locks that the ligands, being the keys, are going to interact with. Okay. So again, communication between cells has to occur with signaling molecules, and some of this stuff is probably going to be a review for you, so probably covered it elsewhere, so we'll talk about it briefly here. But it's important to know the different ways that cell signals can be mediated within the body itself. Again, receptor can be any specific protein, enzyme, DNA, any specific target that these drugs are working with, and the effector is going to be basically the mechanism that is activated by binding to that receptor there. So what is the downstream effect? What happens after I interact with this receptor? Okay, blood sugar goes down, or blood pressure goes up, whatever the case may be here. Okay, we'll talk about second messengers systems a little bit later on. That'll be in the next section. But let's talk about here the first signals, which are the going between cell to cell. So first off, you can have contact-dependent cell signaling. This is where the cells are in close contact with one another. They can directly communicate. This is important when you're talking about things like cancer. Usually when you have cells that kind of crowd around each other, they say, okay, I don't need to replicate anymore. Well, if that gets turned off due to a mutation, guess what? Now you have rampant cell growth, and you have cancer. Okay, that's one type of cell signaling you may see there. And again, drugs can try to mimic this. By giving an exogenous drug, you can try to mimic some of these same effects as you may see there. Other things include paracrine signaling, which basically means you have a signaling cell that will then release a neurotransmitter or a hormone or something like that. And it's kind of going within the local area. Okay, it's kind of letting other cells know in the general area that, hey, this is what we're doing here. Here's what I'm trying to activate or trying to inhibit, whatever the case may be. Okay, see this a lot with like hormones working kind of directly close to one another. Say like imagine like the pancreas or something between like the the alpha cells and the beta cells and things like that. This one's really important, the synaptic signaling. So this is where you have two neurons are connecting together, or maybe you have a neuron communicating with, say, the skeletal muscle or the heart or whatever the case may be here. This is a case where neurotransmitters get released onto a target cell. This is a big target for a lot of our psych meds, a lot of our antidepressants, a lot of cardiac meds, things like that can all interact with this system here. This will become really important when you're talking about how the actual neuronal transmission is occurring. Seizure meds, like all kinds of things are going to be affecting that, as we'll see in the future. And then finally, the endocrine signaling here, this is where basically distant tissues can communicate with one another. So if you imagine, say, the hypothalamus releases hormones that will then stimulate the thyroid gland to produce thyroxine, right? That's an endocrine sort of signaling. Or the pancreas releases insulin to signal the skeletal muscle to uptake glucose for energy production, right? So again, these are a case of endocrine signaling. Again, we can mimic this with our medications, and this is kind of most likely what we're trying to mimic in a lot of cases there. We're giving a drug via the bloodstream. It can then distribute out to the body and affect all sorts of different types of tissues. Okay. So as I mentioned, different receptor types can include things like enzymes. So here's an example, and again, you don't have to memorize these specific examples. We'll get to them in Pharm 1 and Pharm 2. But just to give an example, here's a drug called methotrexate, either used for a lot of autoimmune conditions like rheumatoid arthritis. May see it being used for things like Crohn's disease. We can also use it for cancer. It actually works on a specific enzyme, this dihydrofolate reductase enzyme, and it prevents the recycling of folic acid. By doing that, you prevent cells from replicating because they can't produce new DNA. So again, that is considered the receptor, even though it's an enzyme that has nothing really to do with methotrexate, but because they interact with one another, they prevent that action from happening, and thus you have your cells stop replicating, or you suppress the immune system, whatever the case may be. So again, one example how a drug can interact with these systems here. You can affect transport proteins. This is really important for cardiac meds especially. You guys are familiar with the action potentials and the cardiac cell cycle? Yeah, we'll go over it when you get to the specific drugs here in a little bit. But as an example here, everyone familiar with the sodium-potassium ATPase pump? Remember that? Vaguely, way back in biology somewhere probably. Well, if you remember sodium-potassium pumps, they help to maintain the electrochemical gradient within the cells. They keep them electronegative, essentially, in order for action potentials to happen. If that stops working, you can monkey around the whole system and cause lots of different effects there. So here's an example of a drug called digoxin. Digoxin can be used to modify the activities of that transport protein so it doesn't move as much sodium and potassium, and thus you can change how the heart actually works. You can actually cause it to contract harder to get more blood coming out of the heart when you have CHF, right? When you have the heart that's not pumping very well, you try to increase that pumping capacity for the heart there, right? Again, just different ways we can try to interact with the system and cause different effects. Again, looking at structural proteins. So as an example, we have a drug called colchicine that we use for things like gout. Right? Anyone know what gout is? Can you describe it? Yeah, it's like uric acid crystals are depositing, especially like in the big toe, the great toe, will happen there. And basically, one of the things we can do is a drug that will actually interact with structural proteins. It actually will inhibit the microtubules that the cells use as part of that cytoskeletal structure, right? So again, different potential targets we can use for our medications. So the main types of drug receptors you're going to run into include our ion channels, our G proteins, enzyme-linked receptors, and then finally intracellular receptors. Those are the 4 main varieties we're going to be seeing. Now, again, you can find that when you're breaking down the receptors, you're going to find that they can either work on the cell surface or that last one I talked about, actually working within the cell itself, intracellular. This is where things like can go into the cell and like interact with the DNA to cause changes like in protein formation and things like that. Most other drugs that work at the cell surface, right? They'll have the receptors that are just kind of sitting there on that phospholipid bilayer, that nice membrane, and they can interact and then have downstream effects from there. So again, your ion link channels, your G protein, and enzyme linked are all going to be on the cell surface, and then the intracellular ones are going to be working more specifically on their own. So when I say ion channel linked receptors, what does that mean? Well, basically you have different types of receptors, and when activated, they can open or close and allow for ions to flow through them. Now say ions, what are the common ions you think about in the body? Sodium's a big one, potassium, calcium. Yeah, those are probably the 3 main ones you're going to see there. But it can include other things like chloride can be a really big one as well. Basically, by interacting with these receptors, you're going to open them up and allow for ions to either flow in or out, depending on the electrochemical gradient, right? Because remember, things from high concentrations like to flow to low concentration, right? That's passive diffusion, which we'll talk about next section. But you're going to find that by opening these up, you're going to allow things to flow along their gradient and can cause really big changes. So as an example, imagine I were to say, call on one of you to come up here and say you have to give the rest of the lecture. You might feel pretty anxious all of a sudden, right? Your neurons be firing because you're like, oh my gosh, what's going on? Fight or flight response is kicking up. What if I were to give you a drug called a benzo, like Xanax? Well, basically what that does is it will open up some ion channels that allow chloride to flow in. Chloride's negative, right? It's negatively charged. It will help to hyperpolarize all those cells. They slow down. All of a sudden you feel much more confident. You're like, okay, well, I'm not so worried about this now. I don't know what I'm talking about, but I can just talk about it, right? So that would be an example of an ion channel being activated by a medication to allow an ion through. You allow chloride in, and you slow down the cells. And again, we'll get into much more detail on those when we get to the specific drugs. But that's the crux of it, right? Things are going to flow along the concentration gradient. I can give drugs to open these up. I can give drugs to close these down. It just depends on the setting. Okay. As an example, this things like nicotine bind to nicotinic acetylcholine receptors, right? That's how they got its name, is nicotinic receptor. We gave nicotine for it. We have other things like tranquilizers and barbiturates. We give to interact with GABA receptors, right? GABA is the main brakes on the system. You know what the opposite of GABA is in the brain? Glutamate. Glutamate is kind of like the main excitatory neurotransmitter. But again, they kind of work in concert with one another. Things like calcium. Anyone ever heard of a calcium channel blocker? That's basically blocking calcium from getting into certain smooth muscle cells and can cause blood pressure to go down, right? These are all ion-linked channels, basically, that we can affect with our medications. Next, we have our G proteins here. Basically, these are one of the most common type of cell receptors you're going to run into. Our sense of smell is really tightly linked with G proteins, as you'll find in your physiology books. But basically, there's a huge group of proteins here that are responsible for all sorts of different things, either actually causing cells to grow or not grow, smell, as I mentioned, all kinds of different effects here. And about half of all known drugs work through a G protein receptor. And again, don't get bogged down by the details so much here, but the thing I want you to know is that when you have the G protein here, you have a drug come along, a signal molecule, you go and activate this complex. And once this is activated, you know what GDP stands for? So that's gross domestic product. So guanosine diphosphate, right? It's kind of similar to adenosine diphosphate. When you add on a phosphate to it, that gets energy and it starts to activate. So this turns into GTP here, and then it goes along and has whatever effect it's going to have. So as an example, looking at this target protein here, once it's activated, it then activates the target protein, and then it has whatever effects it has. Whether it's lowering blood pressure or increasing cardiac activity or whatever the case may be, it's all through that G protein signal, okay? Just know that's the receptor type you're dealing with. Don't get bogged down by all the details of the activation and the deactivation, all that kind of stuff. Just know this is a type of receptor we're working with. If you ever look at the mechanisms of your drugs, you may find, oh, it interacts with this G protein. That's what we're talking about, right? You can have enzyme-linked receptors. Do you mind if I go just a few minutes over? Normally I try to be really conscientious of your time. Do you have anything after this? Oh, you do? Okay. Well, I'll go ahead and cut it off here. We can finish this up next time. Anyway, so any questions that I can answer? Oh, yeah, 10 more minutes? Oh, I normally just cut off at the 50 mark. Okay, I'll go for 10 more minutes. You can, if anyone who's objecting to that, you can blame your cohort who said I have 10 more minutes. So I'm gonna go with what they said. Anyway, I do always go 50 minutes and 50 minutes, but regardless. Enzyme-linked receptors, this is kind of similar in activity to the G proteins. I'll show you the picture here in a second, but there's a lot of different kinds, but the main one we see here are the tyrosine kinases. These are the most common you're going to see, and the picture kind of will give you an example of what they look like. But these are super, super important for causing changes in DNA replication, stimulating cell division, and there's actually a lot of cancers that we're now targeting by targeting these specific enzyme-linked receptors here. And so basically what happens is you'll have, and again, insulin receptors do the same thing here as well. You basically will have two receptors, and once they get activated by both signal molecules, they come together, they dimerize, right? Two of them come together, and then they get activated with a bunch of phosphate, and then all of a sudden they can have their cell response. So in the case of insulin, I'll give you more examples next time as well. In the case of insulin, you would then trigger glucose transporters to come up to the cell surface and allow glucose to come into the cell, and thus lower blood sugar, increase energy production in the cell, whatever the case may be. Okay. And then finally, intracellular receptors. This is really, really important for steroids and hormones. So things like thyroid hormone, things like cortisol, all these different things. They get into the cell itself, and then once they're there, they can go down and start to interact with the DNA to either increase gene transcription, they decrease transcription of different products, and ultimately that affects protein production, right? So as an example, if I were to give you, say, cortisol, right, which normally cortisol is produced where? The adrenal gland, right? And when does it get released normally? When you're really stressed out, right? Like you guys probably are right now, right? So anyway, so you go ahead and we'll release the cortisol that will get down into the nucleus and can do things like change the activity of the inflammation cascade, right? They can change how well the immune system's working. They can increase your blood sugar, and all of it's based on how it's actually interacting with these DNA portions here. Okay, that's how it's having its mechanism of action. But this includes things like estradiol, testosterone, thyroxine. These are all considered these hormones that work directly on the actual nucleus itself. So in general, you can see that the enzyme-linked, the G proteins, the ion-linked channels, these are all going to be cell surface active, right? So the medications don't even have to get into the cell; they just have to get to the cell surface. Versus finally the intracellular one that they make it through. And sometimes you'll see that lipid bilayer can actually provide some impediment to that. Sometimes they have a hard time getting through, but once they do, then they work on the actual DNA itself. Okay. So any questions on the first half? I feel I was able to get through it all. But any questions at all so far? Don't get overwhelmed, right? Again, this is just like laying the groundwork for stuff we're going to talk about going forward. Know the definitions, get comfortable with those, being able to describe them, kind of understand kind of the basics of the delineation between the different cell receptor types. And so then you'll find, I think, if you look at the syllabus, which I think I copied on there, which you should have. So your homework assignment 1 is going to be due next week. So I attached it in, I think you uploaded it. Yeah, so you look at that. You'll be assigned a drug. So look at the Excel sheet. You'll find the drug you've been assigned. I hope you like it. I don't know. I did it randomly. And then you will find a homework assignment to go along with that. It'll be 3 or 4 questions you're going to answer. Again, use your own words. Don't just copy and paste, because otherwise turn it in. We'll say that looks bad, and then you have to redo it. Right? I don't want to have to do that. That'll be due next week. And then the first exam is going to be the following week after that. Okay. It'll be going over the first 2 sections here. So again, it's a lot of definitions. It's a lot of these are not going to be like the super hard-hitting clinical vignette sort of questions here, right? Like I'm not going to say, you got a patient with diabetes, hypertension, CHF, what drug are you going to use, right? That's for next semester, right? These are questions like, which one of these best describes the definition of pharmacodynamics or something like that, right? So again, more level 1, level 2 kind of questions here. I really save up till next semester before I really start to hammer you with those more difficult ones, okay? And then we'll go from there. Basically, you have something to turn in almost every single week. But yeah, if you have any questions, please reach out early if you can. Yes, sir.
1 minute each question?
Yes, I will hammer out the details on that. But in general, let's shoot for 1 minute a question. That's how the PANTS does it anyway. But yeah, I'll talk with Dr. Murray and see if there's any differences there she wants to do.
Is it on Exemplify? Do the exams?
It'll be on ExamSoft or whatever you guys are using. Yeah, the standard. Shh. So I will post a link. So when you get access to the actual website itself, which I guess Monday, is that when it's supposed to be? Hopefully, I don't know. I'll get with Dr. Murray about that. But I will post that as a link. It'll come up underneath the PowerPoint itself. It'll just be a YouTube video. You can just go straight to. Yes, ma'am. So if you go to up to date and say you search, so if your drug is say simvastatin, you go to up to date, search for simvastatin, and it'll actually come up as a monograph. You click on that, and it'll take you to what they call LexiComp. Again, it's owned by the same company, so it's all the same there. Yeah. Any other questions? You can email me through Canvas. If you just want to message there through the class, it's pretty easy. I'm usually pretty quick to get back with people. And if nothing else, I guess I'll see you guys next Friday.